The topic that I'm going to be presenting today is a real interesting one, and it's an evolution of thinking. And that is something very interesting because what I did at the beginning of my career, as you'll see, is very different than what I might do now. And we'll see the progression of my thinking over the years. I'm a fully trained periodontist and a prosthodontist. Most of you know me as a periodontist, but actually I'm fully trained in both specialties. And so for the first 20 years of my practice, I did both in my office. Our office, as you know, does both. I have 5 great prosthodontists like Steve you saw yesterday, with a great team. So I've been limiting myself more to the surgical phase in the past years. But I will tell you that I started saving teeth when I started this adventure. So when I graduated, the likes of Maud Amsterdam and great leaders like that at Penn influenced me tremendously, even though I was trained at the time at NYU. So you'll see how it evolved and what happened. So let's have some fun on this discussion today. Let's be open-minded. Now there's a big pendulum that's swinging, obviously, away from saving teeth towards saving implants. I mean, towards putting implants in. Now there's a pendulum back because we have to save implants. You know, so we're holding on to some teeth a little longer, aren't we? So there's this whole balance that's taking place. The pendulum has swung one way and then come back the other way. Because when we first saw implants, and I was part of the first team trained in 1982 by P.I. Brannemark and George Zarb up in Toronto. Well, you know, we had a whole different philosophy at that time. We never heard of anything, we never heard of the implant coming out of bone. We were amazed that it took to bone, it was osseointegrated, and we never heard about peri-implantitis. Partly because that implant was not prone to peri-implantitis, although we don't use it today, do we? Because it was not great for soft bone, as you know. So there was that contrast between the two worlds. So let's take a little adventure. And I think that I love this quote. Now this is, you all know about the Bennett movement? All the restorative dentists and prosthodontists in the room know about the Bennett movement? Well, William Bennett came up with this great line in 1958. I cannot help thinking, and this really says this symposium, I cannot help thinking that the most frequent collaboration between workers in different fields, like different specialties, meeting on borderline subjects would result in the elucidation of questions which present much difficulty to the single specialist. Get tunnel vision. It is one of the most inherent weaknesses of specialism that its exponents must become limited to following the natural trend of their own habits of thought. It is indeed very refreshing to find that just that aspect of a problem which presents the most difficulty to the solitary worker or the single specialist with tunnel vision is really only a special case of a general truth well known to a student of another branch of science or another specialty. Wow. Wow. Let that sink in. That's what this meeting is really all about. So I put that in. It's a great quote from William Bennett. And so this is what the interdisciplinary thinking. Even if you're not going to do surgery, or even if you're not going to do restorative dentistry, you only do one or the other. You must know what the rest of, or lab work. You must know what the rest of the team can do with you and for you. And you must know how to integrate. I think that's pretty clear that this group of all people have shown how to do that. So first, let's go through what I'm going to go through today and have some fun with this. A little disclosure, background cases to see where I was and where I might be going. Went then to real discussion. I went to extract or save a tooth. If we have time, I know we started a little late, the aesthetic zone considerations, which I think are important, and some final conclusions. So now it's often been, the people who don't like when I lecture are mostly endodontists. In fact, the past 3 or 4 years at major meetings, I've been paired up with endodontists. And I'm saying, why are you pairing me up with an endodontist? You know, why head to head, save the tooth, the endodontist. You know, take the tooth out, the implantologist, whatever I am, okay? And so they put me into this category, this opposite the endodontist. And so I think a little bit of disclosure is important because I have the greatest respect for endodontists, and I just want to let you know some of my best friends are endodontists, okay? I have nothing against endodontists, so there's my disclosure. I think it's important for you to know. But we're going to have some fun with that. The problem is tunnel vision. Every specialty, you know, I put up, as you know, I've been teaching for many years. And I'm at Columbia now, and I will tell you something. If I start at the beginning of the year with all the graduate students, the specialty students, I put up a Panorex or a full mouth series of x-rays. At the beginning, the generalists in the room, they're all still generalists right out of school. The generalists in the room, they all look at everything. Within 6 months, I put the same x-rays up, 6 months of specialty training, no matter what specialty it is. The endodontist, their eyes go right to the apex of every single tooth. The periodontist go right to the crestal bone. The prosthodontist go right to the decay and the crowns and what's on there. The orthodontist look at angulation. It is the most amazing thing how tunnel vision we get. So let's stop that. Let's open our thoughts. To be a great generalist, to me, is the hardest thing. You must know what everybody else knows and know what you can do. Know your limitations and know what you need to, when to refer. It is the hardest thing to do. So let's have some fun with this. So let me show you some background cases. No, this is not my first case I ever did. Certainly there are times when things are amazingly go bad. And you know, this was done by some dentist. She didn't. I said, did you put that on yourself? And she goes, no, I would never do that. What are you talking about? I said, well, did somebody do that for you? Do it to you? Of course, my dentist. I said, where's your dentist now? So he's retired. I said, good, that's a good thing, you know. That's a good thing. It's the truth. She says, but I love my dentist. I said, why do you love your dentist, you know? Well, he saved me from, I sat in his chair a lot, and I had to go to a wedding, and he wired me up just so nothing would come off during the wedding, and he got me through the wedding. I said, great, okay. So there's places for take things out. Now, how about this? I was volunteering many years ago when I first got out of school at a free clinic in St. Mark's Place in New York City. And this guy walks in, and at first I didn't know what it was. I thought it was Jaws relived, you know. I said, what is this, you know? So, and he's got a full upper denture, and he comes from Russia, and he had not seen a dentist for 25 years. Now, this was 30 some odd years ago, so this was, you know, the case was done many years, probably 50 years ago. And if you look at it, these were just, you know, crown formers that were welded together. There was no crowns that were cast for this guy and just fitted. But I want you to see the tolerance. I want you to look at what the patients can go through and what the body can accept. 25 years. I said, well, what put you into a clinic after 25 years? You know, there's the question, you know. Where have you been? You know, and what do you go? So obviously he's got all kinds of stuff going on. Well, he had one irritation underneath. Look at all the calculus and all this, and yet his teeth were still surviving. Partly, some of them were free-floating in disease. Some of them had normal bone, despite this kind of calculus. So some were in trouble, some were not. The point is that the body was able to tolerate this, and part of it was because it was splintered together. But some teeth with the same mouth, untouched for 25 years, look great, and some look terrible. So what did he come in for? He didn't come in for this. He came in because he had an irritation under a pontic. You believe that? After 25 years, he got something caught under a pontic, and we had to drill this away to get the stuff out, and because he had a huge ulceration. That was what I did 25 years ago. So it just shows you the tolerance of the body. Let me take a look at through this case in 1982. This was my board case that I did for periodontics. I got my boards in 1985. Let me show you my board case, just a quadrant of the case. What would you do here? Treatment plan the case. Treatment plan the case. Can you see it okay with the lights up a little bit? Is it okay? You can see it, it's rear projection. Okay, so you see there's a bit of a problem here. We've got trifurcated teeth, they're through and through. You've got a perforation out the side of this root. You've got decay down the side here and periodontal disease here. You've got broken instruments in the root tip. Non-symptomatic, by the way. And you got decay coming through here, decay coming through here. So you got an angular defect on the second bicuspid, 50% bone loss on the first bicuspid. What would your treatment plan today? How many of you would save the 2 molars? 1, 2 people. How many would eventually put implants in there instead? Okay, all of them. Okay, all right. Well, this is the controversy. Now, it's not about the apex of a tooth. I have the highest regard for what endodontists can do today. In fact, they have the highest success rate of anybody that we do. They're 97th percentile with microscopes and ability to, you know, to take roots and cover apices. But it's not just about the apex, as you'll see. That's what changes with us. So let's see what I did. This is 1982. So there's a blow up of it. You see the problem. So what we did was I took this root out. I took this root out. I crown lengthened the roots because I had to get something to grab onto. For the restorative dentist in this case was my partner, Dr. Zamzak, John Zamzak, and I did some of the autogenous bone. I put it into the distal of this root, hemisection, and 2 hemisections. So here's the teeth. You see the decay that was there. It's huge, infrabony defects, and then look at the distance side. Look at what I did. I apically positioned the flap, and eventually we just left this. We decided with the endodontist not to go back in here for fear that this tooth would crack. There were no implants at the time. I was just learning about full arch cases with implants. 1982 is when I took the course. And we didn't do it for partially dentalism, did we? Partially dentalism didn't start with implants until 1989, 1990. So in the 80s, we were still only doing full arch cases, a la Brandemark, with implants. Very few of us were doing single teeth by then. So I had a bet with John, and John said, this is not gonna last 5 years. I said, I'll give it 5 years. Obviously, this is gonna be a problem, this one could be a problem, but we have no choice. We had no alternative, and the patient refused to wear a partial. You have any of those patients? Okay, I think so. It did last 5 years. We bet a steak dinner, I got the steak dinner. And so you see what we started with and what we ended up with. That's 1983. Where we are in 1990, it became all implants. It became all implants in 1990. Let's see what happened. So it took 7 years. In 7 years, it lasted. But what failed? The endos didn't fail in this case. It was fracture of the remaining 2 roots. That's eventually what gave way. And so then we wound up putting implants in. Not a great x-ray, but at least you see that we did have normal bone down to the first thread. Where is it today? That lasted, the hemisections lasted 7 years. And I did tons of them then. I built an entire practice on saving those roots as a perioprostodontist, as they say. And so that was what I had. I had lots of these cases. And around 1990, because I started my career in 1975, my office, and so you can start to see that I had a lot of years of backup of this. Where are we today? Here's 2012, 22 years later. Now notice the bone loss has taken place over 22 years. But because, when did it start? And this is what we're starting to see with periimplantitis. We're seeing this on poor oral hygiene patients, which he was a little bit, not great, but he also had 2 rounds of chemotherapy. And we're seeing that with Torsten Yem's work, when looking at the Brandemark cases over 40 years. We're seeing that when the patients get medically ill is when we start to see this collapse of some of the crestal bone loss, and they go through the stages, especially chemo. So we're starting to see that medical parts are definitely hooked into our success, but are they still in the mouth 22 years later and still working perfectly? The answer is yes. They have some problems? Yeah, but minor. Still functioning 22 years later. How many of you have hemisections on lower teeth that are still working after 22 years? Some, but what percentage? I have them too, but the small percentage that are still going in 22 years. This hopefully will go with this patient until he passes away. He's still living, and he still has a good quality of life. Take a look at this case. What would you do here? Forgive the pictures. This is when I first graduated the program, and it was in my private office. The patient comes in and has this defect. So we wanted to pulp test it. The pulp test was normal at the time. That was not the problem. It got a deep angular defect. That's what we did. I opened it up. Look at that trough. What would you do? As a periodontist, I did a bone graft. At the time, 1982, citric acid was real big. Okay, let's do citric acid, debridement, and we used Periograph. Any of you remember that? So citric acid and Periograph, 1982. Some of the old timers are going, yeah, I remember that stuff. It's a hydroxylapatite material. Okay, citric acid, hydroxylapatite, that was the big stuff on the market. Filled it up, and take a look what happened. Nice. Okay, looks good on the x-ray. All you periodontists in the room, always use the most radio-opaque material you can find when you're doing infrabony defects. You are just a miracle worker. Wow, what a periodontist, I gotta tell you. But we didn't know at the time. Notice I didn't put a membrane in, 1982. When did we do guided tissue regeneration? When did we first learn? Mid-80s. So Gottlau's work and Jan Lindy and all the great Nyman, we started to learn about this in the 80s. Because now what do we know that's between this bone graft, even though it took, between the bone graft and the tooth, what's in there? What's in there? A long junctional epithelium. Because we didn't put a membrane in. We didn't know that. So Freya Kosh showed us that years ago. And look, I have the re-entry. I have this here. And look, I did a re-entry. Wow. Let's see what I started with. Wow. Huh? I better publish this. And so I did. I published this case in the case report journal. So here's the before, here's the after. And we published it. Paul Fletcher, my partner, and I published this in 1985 with, like a 3-year postdoc with a re-entry. Beautiful case. If every 10 millimeter trough like that filled with bone the way that did, we wouldn't have to do hemisections and we would save a lot more teeth. We don't have the magic bullet yet. So for every one of those, I'll show you 5 that at 10 years didn't work with 10 millimeter defects of that kind of sort. And that was pretty amenable to fill. But what happened to the tooth? Let's watch it. Let's watch it. I published it with a re-entry, right? Good results. 1988. This is 83 when we finished. 1988, I want you to see this. It looks still pretty good. Everything's intact. So there's your 5-year post-op. Pretty good, not bad. All right, what happens now? 1989, the patient comes in, I says, I have some pain. So 5 years later, I got some pain. What do you see here? You see this breaking down. You see this breaking down. So we did endo, good endo. Look at all you see the Christmas tree, you got hot gutta percha, you got all the stuff, you know, you got everything you want. Nope, that didn't work. So 5 years later, this tooth that I published and told everybody, look how wonderful I am, look how great this is. And this is like, Joe, this is how humbling. I loved your stuff today, Joe. It was great. I don't know if Joe's still here. Joe, you still here? He was here a second ago. I don't know if you had to leave. But that was great because he shows that 5 and 10 and 15 years, not just 3 to 5. Because we're so, at least we got 3 to 5, we know something's good or bad to start. But this is what is very humbling, isn't it? So you start to see that we wound up taking one root off, then the other one failed, so we wound up taking both roots off. So after all that and publish it, it lasted about 6 years. What about this case? That's the patient's bite. This is the patient's bite. The first tooth that's contacting is the second bicuspid. And this is the way, this was a clinic patient, came into the clinic at the time in the perio clinic. And take a look at this defect here. Take a look at this, treatment plan this for me. Impacted third molar that's communicating with the tooth, with the outside world. So there's a defect in here. You got down to the apex, and although it tested vital, we did the endo just to see what would happen, to see if it, remember we didn't have any other things to do. Maybe it's an endoperio lesion. So we did the endo and took out this root, filled that up, but the endo didn't do a thing. We were hoping the endo would, you know, create the nice fill, which we've all seen, but it wasn't. So what do you do here? What's your treatment plan? You got an impacted tooth, you got a tooth down to the apex, and obviously decay everywhere. Take a look at this. So we did the endo, nice endo, everything's fine, still there. So we did a graft. We did a graft, and you see I did the periograft, the same thing. And by the way, look at this resorption here, from the citric acid maybe. Citric acid, periograft, 1982. Let's watch this case, 1982. Today I would have taken that root out probably. I would have taken it out and put an implant in. I think most of you probably would agree with that, right? Okay, but here's 1982. Here's 2012, 31 years later. 31 years later. 31 years later. So you see, this is still, and by the way, take a look at something interesting. Notice the resorption that I told you about? Look what happened here. What's that? I don't know. She's still alive, and hopefully she'll dedicate this tooth to me. But donate the tooth to science. But that looks like a new ligament space. It looks like I have ankylosis of the bone graft in here, and it looks like a new ligament space right in the middle of my graft, doesn't it? No symptomatic, not symptomatic, and no probing depth. So it's just kind of interesting to see what you see at 31 years, and yet I would take that tooth out today. But here's the real question. Would I do these things again? And the answer today is rarely. You'd have to push me real hard. But it did show so you hear what periodontists say, why are we taking all these teeth out? We should save the teeth, do perio, do grafting, do everything. I understand it, because we all have these successful cases that lasted 10, 15, and 20 years. And I know you'll probably see that later this afternoon too. It's definitely possible to save these. The question is what percentage are there? And we'll get to when we decide today. So, when do we extract or save a tooth? Well, basically, it starts to be a list, isn't it? And you know the list. We can go through this quickly. The size of the defect, the restorative needs, and that's a big thing. If I have intact teeth and I have multiple periodontal defects, I play periodontist. If I have no restorative needs, if I don't have to put a crown on a tooth, nothing more than a small filling or something like that, I'm looking to be a periodontist then. I don't have to worry about putting a restoration on a 10 millimeter infrabony defect. Restorative needs change everything. Endodontic status, unless the apex can't be sealed or easily, that's really very rare today. Periodontal breakdown rate. What's the rate today in the patient, not 10 years ago? What is the decay rate now, not 10 years ago or 20 years ago when they were a kid? What is the aesthetic considerations, which we'll hopefully have time to get to at the end, because sometimes we'll save teeth strictly for aesthetic considerations, even though we might normally want to take them out. And emotional needs for the patient. Some patients say, I'll do anything, but I never want to lose a tooth. If I lose a tooth, I'm going to die. You've all seen patients like that, right? If I lose a tooth, Dr. Tana, I might as well shoot myself. I don't know why, but you know, these people should really see what life and death is. They go to a hospital and you see what really people are going through. Anatomical considerations. What is this 10 millimeter rule? That's my own arbitrary rule. If I have to do the crown lengthening that I did on the first case that I did my boards, by the way, I passed my boards with that case. On the first try. Okay, but the 10 millimeter rule. What's the 10 millimeter rule? I always say to my students, if you have to do crown lengthening on a tooth, the hemisections and decay is taking you down below 10 millimeters of bone to the nerve, or 10 millimeters to the sinus, And although today we are better off with shorter implants, now it's, I'd say, about 9 millimeters, certainly even 8, but I want to say about 10. If I have 10 now and I have to go down to 6 to 8 millimeters of bone, I'm going to take away 2 or 3 millimeters of bone height just to grab a ferrule effect on the remaining roots, I stop. So a lot depends on the anatomy. That's my 10 millimeter rule. If after osseous recontouring to save a root, I'm going to be down below 10, I stop and say, let's talk. I might want those 2 or 3 millimeters back 5, 10, 15 years from now. I'm not willing to take them off so quickly. And status of adjacent teeth, of course. So this is your list of things, and there are others. Age is maybe one also. And financial considerations, of course, always play a factor. So, treatment options. So I'd like to talk about something with the endodontist did. It's a good template. In 2011, the endodontist published a little series of articles, or not articles, a series of, it's online. And you go online to the American Association of Endodontists, and they talk about, let's see what an endodontist can do for you. That's great. We know what an endodontist can do. They can seal apices. But watch what happens. Let's take some of these rules. Let's see what we do. This is from their booklet. So number 19, large periapical radiolucency, post-op, 15 months. Did it all work? Yes, it filled in beautifully because it was pure endo. Would I do this case the same way? Yes, I think that's the perfect case. You do endo and get this done, of course. Okay, it's an endo lesion. Let's do it. I agree. What about this tooth? Decay on the distal. They did a hemisection. They just did this one root, leaving it out like this by itself. Now, it doesn't look that it's fused to this other one, to this other tooth. Would I do that today? No, not. This is an emotional decision. That mesial root is not strong standing by itself unless I'm already recrowning the other teeth. Then it's okay. But by itself, that one doesn't last long. What's the most common reason problem? Fracture of the remaining root. And Bert Langer showed us that in his 10-year study. So we have to be cautious. That doesn't mean you can't do it. The question is, should you? What about this one? Same thing. The distal root is gone. Save the mesial root. I'm not sure I love that. That's not as a terminal root by itself. It's not my first choice. I don't love it because I've done those for years, and they don't last to 10 years. They can. I have some, but percentage-wise, it's down. This is part of the reason. What kind of post can you put in? Remember what Bowers showed us? 90. This is not Jerry Bowers. It's Jerome Bowers from Robert Bowers from in '75. From Australia showed that there's 99 to 100% of these cases have a concavity on the furcal area. Most of you have not been trained in furcations. We did these lectures in the 70s and 80s, and if I had the lecture today on furcations, you'd all be out the door. You wouldn't even want to listen to me. Who wants to listen about furcations? Furcation management. Have a good day. I'll take the coffee now. Really, it's what happened. Okay. But you know, there's anatomy. This is basic stuff that we were taught because see the perforation here. This student was going right down the center of the tooth, but he forgot that there was a concavity there. So if you just do like a meta-analysis, so to speak, of root resection therapy, you start to realize that, you know, you see Langer's article was great, Clavin's article, you start to see the percentage of success. If you take the whole thing, some are higher than others, but at 10 years, 38% were failure rate. Not a great number. So people say, I want to save that root, I want to save this hemisect and all that. Now, the distal buccal root of a maxillary molar, if the rest of the tooth is fine, I'm still hemisecting. Otherwise, I'm not easily hemisecting for long term. Because of this number, 15.9%, that's very high. If you take a look at the single molars, this was years ago, but now it's even better, it's about 3% to 5% max failure. So for single molars, instead of hemisections, if you just take molars, the numbers are 0 to 3 to 5%. I'll take that any day over 15 to 16% averages. And that's what we're seeing, and that's the reason. And this article just came out recently in 2012 by Spielman. And this is a group of general dentists doing their own thing, looked at and monitored by this Pearl group to see what they're sponsoring, not just the highest level experts in the field. What's going on in the real life general dentists? And take a look at this, look at these numbers. This is restorative failures for primary endodontically treated teeth. 3 to 5 years, not 20 years, not 10 years, 3 to 5 years, 1,298 teeth. Look at these numbers. Number of failures, 44. Look at these percentage. The total failure rate was 13.9% at 5 years. Just an endodontically treated tooth. Wow, that's a regular average dentist that they tried to trace what would happen, not the greatest clinicians in the world. Wow, whoa, are we in trouble? Of course we're in trouble, and there's a reason why people want implants. If they're done properly, at least they're starting with a clean slate. Just because we can't save a tooth does not mean that we should, and that's really part of what we all have learned, isn't it? So what about this? Number 19, large periapical radiolucency. You fill this up, this works out well. The answer, of course, do that. I'm still doing this. If I know that it's an endo lesion, of course, try the endo and save the tooth. This I'm not thrilled about. Can you save the tooth? But look, this is going to crack on this patient. It's just a matter of when. You got a lateral perforation, you got a periodontal potential problem. So from an endodontic standpoint, sure. But from my perspective, that would not be my first choice. I would much rather put an implant into this on a long-term basis. Doesn't mean it can't be done, but it shouldn't be done. How about this as an external resorption? This is from their paper, so take a look. External resorption. I don't like that idea of when you have that. Just doing endo on this doesn't mean a thing. This patient has aesthetic problems, crowding problems, and so on. So take a look at Francesca, one of our cases. And you can see that this patient has thin scallop tissue, and also you can take a look and she has external resorption. So I did this case with my partner Steve Chu that you saw yesterday, and here's the external resorption. So it's not about the endo's fine. The endo is fine. How do you get to this area? How do you treat and plan for this? This is the problem. So we decided to take this out. As you see here, you see the lesion, kind of an unusual lesion. We took it out, as you see here. Then all this stuff, and Joe, it was a phenomenal presentation today, and we're good friends, and we've been bouncing this stuff off each other. The key is not to open a flap. I'm still convinced about that. Because you have to look at these cases and look at the numbers from Iacella and others and Lekovic, and I mentioned it to Joe afterwards, that those cases where they showed the resorption, even a buccolingually of 1, even with a grafting of 1.1, 1.5, like Lekovic, they open the flap. And just opening the flap causes most of the problem. We're starting to see in the past 2 or 3 years that if you don't open a flap on these cases with the buccal plate present, that the amount of bone change is about 1 to 1.1, 0.8, 1.4, not the 3 to 4 millimeters that we saw with the Lekovic and Kenny article without a grafting. So, and also the placement must be towards the cingulum. I can't tell you how important that is. I know he emphasized it too. He was at the incisal ledge on some, even out the buccal on a couple, but they have to come out the cingulum. That gives you that gap distance to maximize it, and you go up the palatal bone. So the rest fills in, and that's the other key part to this. And that's what our research is. We put the implant into the palate. Here you see the placement. It's not today's purpose. You see the nice smooth profile to support the tissue. And this one, today we are grafting based on this research. This is one before we had the research. Today we are definitely grafting the gap. We're grafting it with bone, and which bone graft material we're still not sure is best. Do we want something that doesn't go away? We may want something that doesn't go away, such as the bioos, the endobones, any kind of the bovine bones that are sintered that don't go away so quickly. We may not want the allograft that goes away quickly because of the 15-year data. We don't have too much of that, 10 and 15 years. We may be looking at this. Now, Boozer is looking at it at bioos at about 3 years. That's when he opened the flaps at 6 to 8 weeks later, going in early. And he's got good results at 3 years. But we'll have to see what happens at 15. And that's going to take us time. And which graft is better, we're still not sure. Now, we do want to do screw down provisionals. We do not want cemented provisionals. We want to get adherence to this as it's a separate lecture, but we want to get adherence to this. And here's what you see at the day of extraction. Good support of this. And just doing that alone makes a difference. There's 1 week. And this is 3 months. Take a look at that beautiful tissue. And what we see is the beautiful scallop, almost no collapse. This is without a graft, as it turns out, even with thin scallop. Now, I like doing these thin scallop cases because of the papilla. If you don't put anything in there and you let it collapse, they are the hardest to get the papilla back. So for the thin scallop, I actually now, with a graft, I'll usually put a graft in today routinely because we see only 1/10 of a millimeter change when we don't open a flap, put it towards the palate, and go up the palatal bone. That's the missing piece. And I didn't realize how difficult that is for some clinicians. Everybody's going up the apex. Everybody's going up the apex. No, that's when I see people say, I'm having trouble coming out the palate because they're going to the apex and trying to come out the palate. You've got to go 2/3 up the palatal of the socket. Break through that cortical plate on the lingual with a sharp burr or a round burr. Then redirect and come through. Even if you have to start it off going this way just to break through that lingual plate. Don't let the burrs have a tip that have a 45-degree angle, the 2-millimeter twist. That'll carry you right up to the apex. That's the mistake that we've seen when I go back and look at people's cases. So we go and break through that palatal wall, and then we have that beautiful bone on the palate. And it also creates, like Joe was saying, give me the big gap. Love it. And then fill that with bone. And don't open a flap still as if the buccal plate is there. And we see this bleeding, and we have a paper that's going to be coming out soon. It's been accepted for publication about this bleeding. When you see it at 3 months, the reason why I don't want cement, when we see this bleeding, when we take it off, that means I had adherence. And even one abutment one time, which Henry and you guys came up with that great term, that's still the best. But we did 3 or 4 changes on these cases. And yet we find that if we get this bleeding, and we have that bleeding after 3 months, when we take it off the first time from our temporary, we have our best results. But we get 10 millimeters change versus 1.2 to 1.5 millimeter buccolingual change. So the reason is that we get this adherence and the tissue's maturing. Don't keep taking on and off. Let it stay for about 3 months, and then you take it off. And then that seems to be a maturing where you can take it off multiple times. And even though the attachment moves down, the thickness of the tissue seems to withstand what we do. And we have data on that. So that's not for today's purpose, but just to save a tooth. Then, of course, the custom staining. Here you see Adam doing his work with color and shape and texture. And you can see that we have a fairly good result. And yes, sometimes we do see the darkness through this. And I agree with you that sometimes even on cases where we graft, we see the darkness. And you can see the case here, it looks good. And there's no real depression here. This is what we started with. And this is what we ended with, as you see here. And you see that we have a normal contour here. Now let's go back to the endodontist. 19 external resorption. When it's this deep, what do? Get it out? I agree. I agree with this. Don't bother with it. What do we do here? This case is from our office. This patient comes through. The hemisection was already done by nature. As you can see, it's already decayed right through. Didn't have to cut it through. So what am I going to do today? Today, knowing that the gap fills in based on our data with Mr. Prolongo's case, that one case report, we're not worried about gap distance. I don't want to do osseous recontouring down to the 10 millimeter rule. I don't want us to do osseous to save this. That's ridiculous. How many of you would save this tooth and save both halves? Be a mistake today, especially since we have to apically position and take good bone away. So today, what do we do with this? Today, Periopros 101, taking the tooth out and putting the implant into the remaining bone. Buccolingual stability, put the implant in, grab the bone, here it is, all healed, didn't even do a graft in this one, because it's in the posterior part of the mouth. I'm not worried about it. You can put a graft in if you want, but you don't have to do anything. In one day, you did all the surgery with a post sticking out. And the clot fills in and does nothing else. It's not today's purpose, but I just want to show you that. And here it looks like it's suspended in nothing. But it looks like radiographically it's suspended in nothing. Here you see it 6 months later with the post and crown and the bone fills in. So that's what we do today. So what about internal resorption? This is one that you can do. Yes, if you have something like that, go ahead and do the endo. That's fine. But what about this one? What are you doing after this tooth for? This is an endodontic nightmare to do. And it doesn't mean that you have a great success rate years down the road. So yes, you can do this, but why? Why do that today? It's not the best treatment plan. You don't even see the restoration here. Notice that this is an endodontic decision, but it's not a great prosthetic one. How many of you would like to do a post and crown on this tooth now? Notice the chip over here. Would you like to redo the crown and put a post in? Wouldn't be your first choice, would it? So what we would do today is if you have this and the break is up here, sure, save this root, do the endo, this is different. Now you have a ferrule effect, you have anything you want. That's a yes. So you can see it depends on what's left. And we all know about the 2 millimeter ferrule effect that you want to have. That's what you need. So that's what you need for your material. So you take a look at this and what they showed. Yes, how about this case? Horizontal root fracture. Yes, that's okay. The answer is yes, or maybe no. Depends on what else you have to do to the tooth. In this case, it probably was okay just to go and treat it like an endodontist, get rid of the problem. But what do you have left restoratively? And I'm also worried about this line right here. It looks like a crack. See that line? So it's still not in great shape. What do I do today? What I do today is let's take a look at this case. High smile line, but this person has a fracture. You see the fracture line right across here. So we're going to have to take this left tooth out. The buccal plate's there. Go in with small instruments. We'll go through this quickly. That's cracked, as you see. Now you got to take that root out. Broken roots, fractured teeth. We take it out, rotate it out. Okay, buccal plate's there, and we go to the palate. And we're going to platform switch, as Joe said. The platform switching is definitely here to stay. And we have a gap in here. This tissue is a little thicker and flatter. There's the nice emergence profile that Steve put onto this. And then we got this contour that stayed out. We stained it, as you see, did the custom staining, placed it in, and you see now we have proper support. And then what we do is we take the crown off. Here's the key to get the bone graft in. After you got the crown completely made, out of occlusion, no protrusive and no central contact, this is temporary, then you take it off. Put the straight healing abutment on from whatever company you're using, and pack the bone. Now you can pack the bone. You have direct access into the opening, into the gap. So we pack the bone in here, as you see here, pack it firmly in, all the way up. And that's how we graft the inside right up, and I call it dual zone socket management. And we published on this concept. Steve was first author on that at Compendium, and we call it dual zone socket management. And that's what we did on the new study that we just did. We packed this bone in, as you see here. Now you have the temporary ready to go. You take it off, and it's stacked in. And it's in a little bit of clotting lets it stick, and it doesn't move. And now you take the temporary that you've already finished, right, and now screw it right down. Boom, the excess comes out, and that's the way we handle these cases. To the palate, maximize the gap by being the palate, coming out the cingulum, no cementation at this point. Even if the final crown is cementable, this is what we prefer. And this is what it looks like. We just took that little piece off, and this is the way the patient walks out. With the graft in place, that's the way the patient walks out. So they come. This, by the way, is one of the best practice builders we ever do. We're doing this at least once or twice a day. A day. That's how often we do this, at least once a day now. This is how frequently this is starting to take place. And people are referring in their friends and everybody else when they have this. They say, you can't believe it. I walked out with a tooth, and I lost a tooth, and my new tooth looks even better than my first one. And that's just a temporary. And here it is at 1 week. Still a little redness. Here it is at 2 months. It looks like we didn't touch the patient. This one moved in only 0.2 of a millimeter after 6 months. And you can see you're sitting right on top of the patient's face, and you can see that this is really no significant change compared to the contralateral side. Minimal to none. Whether it stays that way after 10 to 15 years, we're not sure. We'll see. Here it is at 4 months. And then we take the temporary off, as you see here. Beautiful sculpting of tissue. The particles are thicken the tissue, as Joe said. They thicken the tissue, and that's what we're looking for from the grafting material. There's the graft in place. Here we got bleeding, which is what we like. Then we just took the impression. Steve then made gold-plated the crowns, and here's the final crown in place. And you see, here's the final crown in place, and you can see that we have a beautiful result with minimal change in height and width. Now this was thicker, flatter tissue for sure when we started than the thin one that we did before. But this is what we do routinely, and this is what we reported on with our multi-center study with the Garbers and Salamas and the Saniqueros from Buenos Aires. So you can see this is what we get. No connective tissue graft, no flap. So if the buccal plate's there, this is what we do. Go to the palatal bone, place the implant, place a graft, and hold the tissue out with the provisional, and this is what you will see. I guarantee it. That's how I can tell you that I very rarely guarantee anything. With very rare exception will you see a problem with that. As long as the buccal plate's there and you're being honest with yourself. If it's more than 5 millimeters away from the free gingiva, there's no way that you should be doing immediates. Not in the aesthetic zone, okay? Because then it's a crapshoot. Roll the dice, because you're not sure if you're going to get that recession. But if you're 3 to 4 millimeters away, like Joe was pointing out, with John Coyce's work, if you're the only classic 3 millimeters away, you're a winner. And here's the full occlusal view, looking right up from his chin right up. You see there's no change, and minimal discoloration. And there's the final case in place. So in terms of what retrospect, what would we put in for this instead of this? I'd rather commit this patient to this. Long term, I think that's a much better result. I think that's going to do better than this, half a tooth with a crack line sitting on the side. So, what about number 5? We got a cracked tooth here. You got a crack? Yes, but where's the crown? They did the crack, they sealed it off, but where's the crown? The crown wasn't put in. So you can't just think about endo. You have to get the crown done as soon as you can to keep the two parts together. Number 6, large periapical area. Before apical surgery, post-op, right here, and you can see it. So yes, this is fine, that's great. But you take a look at this. Number 8, retreatment. Now, retreatment's a big problem in the world of endodontics. Should you do it or not? Well, if you see a deficiency in the endodontics and you have access, by all means, do it once. But then go ahead and do it and dry it up. But only do that once, okay? Don't start repeating it over and over again. Otherwise, this tooth belongs out. And back there, an apical is not really indicated too easily. What about a tooth like this that needs endo? Now this is interesting because when Jesus came in, she was complaining of pain in here and this tooth was got a fracture. So what do we do today with molars? Once a patient, now notice the previous cases we did, everything's fine. So the patient feels very comfortable with implants. She says, I don't want to go through endo again. I don't want to save this tooth anymore. She's telling us, I don't want to do that anymore. I already invested into that tooth. Take it out and do what you did on these tooth. And so once a patient has successful implants, they usually request an implant when given the choice. And so that's what I did here. So in this case, we used a wider body implant because the septum was gone. So here you see a wider body implant engaging the side walls. That's today with the post. This patient went away to Southeast Asia. She then came back, and so we waited 3 months. In this case, Steve waited 5 months before we were able to take it off. But notice the beautiful tissue at 5 months. It was with nothing but initial stabilization and a healing abutment. The surgery was done. Then it's just taking a UCLA type of crown, and there's the final crown in place, screw down, and you can see the bone filled into what we have, and it filled in perfectly. What about endodontic considerations? Do not excessively widen canals. Look at this guy, loved to widen canals, whoever did those endos. And by the way, make sure that you do the endo before you do the post, okay? That always helps. And you also have perforations, don't you? You have perforations down here. You got to be worried about that. That's that canal like I was talking about before. Very classic. And you're 5 millimeters away, and from the front, you're straight down the middle. But if you use a post that's a little too wide down here, have a good day. You perforated. That happens all too often. And screw posts, of course, can be just a nightmare in terms of fracturing roots, as you see here. So when to extract a tooth, we've gone through all of these different considerations, okay? So what about when do I tend to save? When do I save a tooth? I seem to be only taking them out. No, we do save teeth. One, when I want to keep an intact arch. That's when I'll try to save it, okay? Two, treatable endodontic needs, of course. No major restorative needs. And I have deep periodontal problems, that's when I play periodontist. My 10 millimeter rule is not going to be violated. I'm going to regenerate bone, fine. If I have to do osseous recontouring and I go past 10 or 9 millimeters to the apex, to the canal, to the nerve, then I'm in trouble. And decay rate is low. Why am I saving roots? And the number one reason to redo crowns is caries, recurrent decay. So why would I save a root? Because once I put an implant in, the number one thing that the implant does, it doesn't decay. Now granted, periodontal problems can still exist in the future, but we have lost decay as the number one reason to redo crowns. Wow, and that's a big to-do. And if the periodontal rate is now low, then you can start to think about saving teeth. And it's not in the aesthetic zone. Why do I bring that up? Because if it's in the aesthetic zone, sometimes in order to do an apically positioned flap and get recontouring, like the first case I showed you, Francesco, to get to that external resorption, I would have had to deform the patient cosmetically, as opposed to getting a beautiful result. I would have had to deform the papilla, get possible shrinkage, and hurt the patient in the long run aesthetically. And so if you have to mutilate the dentition, anybody can apically position a flap and do osseous recontouring. The question is, what did you leave left? How many embraces did you leave open? Can this patient's speech problems, or did they create speech or phonetic problems? So this is the problem. So here's when do I tend to extract. If the patient needs crown lengthening, endo and post, on a tooth that's already got a crown, this is almost an automatic today. Redoing crown lengthening procedures over and over again. And certainly the patients that have salivary flow problems, you know, Sjogren's patients, don't do them every 3 to 5 years. That's an insult. These patients do very well with implants, and they don't decay. So if a patient has a salivary gland problem, salivary flow problems, just get the endo. Don't keep doing endo, post, and crown, and apically positioned flaps. The surgery will leave less than 10 millimeters. High decay rate. Periosurgery will create aesthetic problems. Shallow vestibule because you can't do a good crown lengthening. Or class 3 furcas that need major restorations, or deep class 2s with deep vertical components, what I call 2B and 2Cs. Now, the list against saving teeth is like a pile. It's what I call the ideological pile. It builds and builds and builds. And so each one becomes a factor if you save a tooth. It's all in the math. Let's add it up, okay? Let's add them up. What percentage of success or failures do you get from what? Well, so the tooth support occlusion. How many occlusal problems do we have in terms of failures from fracture of the teeth? What is the decay rate of the patient? That adds maybe 3 to 5%. This may be 3 to 5% cause of failure, maybe more. Periodontal rate over years, maybe another 3 to 5%. How about how many post-course failures, as we see? That adds up, add 3 to 5% to each one of these on the side, and suddenly you have 15%. And fracture of the tooth. Each one of those, you have to add them all up, and suddenly, on a questionable tooth, you're adding them all up. Doesn't mean you can't save it. The question is whether they all up to be at least much higher than a 3 to 5% success rate. And endo failure rate, another 3%. Not bad, but add that to 3 to 5, 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 and suddenly you have a list of things that the reason why these teeth don't hold up as well. Just because we can save a tooth does not mean that we should, and that's certainly the take-home message. We must always think multidisciplinary and avoid specialty tunnel vision, a la Bennett. This is the classic mistake that so many people make. And lastly, do I have 5 more minutes? I know we started late. I think I'm still pretty close. The aesthetic considerations are critical in this area of when to save a tooth. Here, you'll see me sometimes deliberately save a tooth, and the Garbers are certainly, and Salamas have published things about even saving root tips on the Pontics and so on for aesthetics. So let's take a look at this. Well, when do I save a tooth? Okay, you probably say, does he ever save teeth? Yeah, of course I do. I save a lot of teeth. I told you when. Well, if a patient has an emotional breakdown when you mention the word extraction, and sometimes they do. Here's an example of that. This patient is borderline. Could you redo the endo, get the post out? Yes, we can, but should we? In this case, she was emotionally fried when we talked about the possibility of an implant. Can we redo this? Can we take the post out and get this out? Yeah, but we have, and then take care of the apical area? Yeah, and we did that. We got the post out. We redid the endo, and this is still a lesion there, but this went away. And yes, we saved that tooth. So yes, we can save teeth. Will this patient 15 years from now still have this tooth? I don't know, but it's something which we can do for emotional reasons. And here's the other one, and certainly I've published extensively on this, knowing about 2 implants and the papilla problem between 2 implants since the year 2000. This is old news, except for 2 centrals, as we heard yesterday, where you get a papillary illusion, where you have a shorter papilla, but you can get away with it because it's in the middle. Mike Sonic said that to yesterday, and that's classic. Where you don't want 2 implants next to each other is on a high smile line, a central lateral on 2 implants, and a central lateral on 2 healthy teeth. Unless they're all short. You saw some yesterday. Some people got away with work yesterday because they did 4 in a row, but they had a scallop. It was all short. Instead of being 40% of the length of the papilla, should be 40% of the length of a tooth. That's the normal that Dr. Chu and I and Hockman showed, and Stappert. But that's 40% of the normal height. But what's the problem here is what? You're going to be maybe 20%, but they're all 20% and don't have a black triangle. If you're able to square off the teeth a little bit and still make it look good and do some custom staining like we saw some of the people do yesterday, you get away with the scallop. But it's not the first choice. So take a look at this. This is the classic that woke me up. This was the first case that I did that I saw 2 implants next to each other, and I had a papilla problem. This is totally short compared to this. The papilla next to the tooth over here is fine. Papilla over here is a little short, but it's there. Here it's 2 millimeters short, and I couldn't figure out why. This was my first wake-up call. The good news, this guy had a low smile line, so I didn't even have to use pink ceramic. This was in the late 80s, early 90s. I didn't even know what was going on. This was the beginning of the papilla discussion of 2 implants. We never saw that before. So I'll show you the first case that just blew me away in terms of I couldn't get the papilla to come down. It wasn't until later that I realized that we had this problem because there's no supracrestal fibers, as there are on the tooth. And that's why the papilla is a problem between 2 implants. It's not just the bone level, it's also there's no supracrestal biologic width. The biologic width is subcrestal on these implants. So let's take a look at this patient. She came in and flew to New York to see us from England, and you can see that she has some recession here, but let's take a look. She was thrown by a horse, and look at these 2 roots, central lateral. And she wants it to look like the other side. She wants it to look normal. She wants it to look like this. And she's got bone loss up to here and loose teeth. So what do? In this case, we did, the endo was vital, by the way, but we did the endodontics because we're going to force erupt these teeth, right out of the Salama or Garber article, enforced eruption. And so hopeless tooth does not mean a useless tooth. And I think Saul Schluger was the first one to say that. So here, Mark Hockman in our office was going to force erupt these. We devitalize these teeth, so we're not worried about endodontic problems. Devitalize the teeth, let them come down. Now look at the papilla formation, because you've got to really erupt it past the pocket depth. Don't get frustrated. If you have a 7 millimeter pocket, and you want that papilla to come down, you've got to erupt it past 7 millimeters before you're going to see the attachment. So don't get frustrated by, I force erupted, but nothing happened. Well, that's if you have a trough around the tooth or pocket, you've got to erupt it past the pocket depth in order for you to start to see the advantage, okay? So midfacial, here you see I thought I had everything. So now Mark did this, and we did it slowly, and we waited 3 months after the movement so that the bone would catch up. And I thought I talked to this patient about grafting, vertical grafting, all the stuff we saw yesterday, pins and titanium mesh. I had her ready for all of that. Multiple surgeries. I didn't have to do anything. Orthodontics alone did this, but watch. So we got all this movement down, and what you see is the bone filled in. So I took out the worst one, this one here, and then I had all this new bone. It was all the way up here. We built up all this bone vertically, put the 5 millimeters of bone. 6 millimeters bone. I put this in, and I had bone everywhere. And so I was able to put this in, without even opening a flap. Then when we looked at this tooth, this was weak. So we prepped it, and we tried to see if we could keep it separately. It was reduced but healthy periodontium. There was no pocket depth now. But what does it give me? This is sometimes when you have to should save a tooth. If it's healthy, and this one was now, the pocket depth was erupted out. It was shallowed out. So it was a healthy, reduced but healthy periodontium. So why? I was ready to take it out and put a Pontic in. But based on the Salama Garber article about the Pontic depth, remember Pontic is good, but the tooth is still the best. So remember, an ovate Pontic is second. 2 implants are the worst. But you gain an extra 1 millimeter if you have the tooth there versus a Pontic. So I kept this tooth because it was healthy, and I had Zemzak, John Zemzak did the press on this case. And I said, listen, just splint these 2 together, which you rarely do, right? But you don't, no movable parts. And that's the way to do this. You cement it on. For a week, you put it on with temporary cement, and this is a zirconium, 2-unit zirconium bridge, and then we just cemented it on, and after a week of being comfortable and everything looked good, then we put it in with strong cement, so we're not worried about vertical depression of the root, of intrusion. So you don't do this often, but this is where you should save a tooth in the aesthetic zone. It's another reason to save it. So here's the splintered case with the tooth erupted, and as you see here, this is the result. It's still not absolutely perfect, but it's absolutely wonderful for the patient. That's the implant. That's the reduced but healthy tooth, splintered together, and I think I'm very happy with that result. So this is the kind of thing where we save the root so that we don't lose the papilla. And this is what we started with bone loss all the way up to here. So in summation, it's real simple. We must always think multidisciplinary and avoid specialty tunnel vision. I think I've shown you that, and you've seen that in the past 3 days, and you'll see it for the rest of the afternoon. And just because we can save a tooth, and sometimes we should, does not mean that we should all the time. And that's really the take-home message. Multidisciplinary thinking, do the best dentistry you know how, know when to refer if you don't do it yourself at the highest level, and that's what it's all about. And I thank you so much.